Guys, do you hear me? Huh? But you hear me? Yes, good evening, our esteemed viewers. Welcome to the tower once again. My name is Dr. Juko, as usual, the host and the presenter of our show. Today is a Sunday, and we usually have this show in this evening. Right now, I believe everybody is settled and has a very good week, has had a good week, and I believe things that have been rotating within the week are some of issues that we pick and discuss on this show. First of all, today we're going to look at the healthcare services in Uganda and how can we really get the best out of this discussion. And after all, it's we that are Ugandans, and it's we that have to make Uganda the best place to live in. We have couple of examples that we can give that can make a very good example, or which can be drawn within Ugandan context. And in the discussion, we're going to look at various healthcare services in various countries, after which we shall look at Uganda in particular. Ugandan healthcare service is in a state of bewilderment as people struggle with the poor services. The rural access to health care remains a challenge, particularly in Uganda, because urban settings are affected by social determinants of health, transportation-related barriers, healthcare systems, and often lack of equity. All these bring a very big problem in people accessing the health care. And you know, everybody knows that health care is the backbone of human life. If you don't get enough care, you expect not to survive properly. We need to look at our lives, and the way we take care of it makes the difference. Today, I have many guests, and with me in the studios, I have Lawrence Semugoma, the forensic analyst, and usually with us here every Sunday. Lawrence, welcome to the tower.
Yes, Dr. Juko, thank you once again for your kind invitation to be part of the tower. It's always a pleasure and a very welcome opportunity for me to share my perspective on a number of issues that are affecting our people, in fact, not just here, but back home, and trying to use the experiences that I am going through, or that some of us are going through here, to forge a way forward, or a way to make our systems back home work better and for our people. Thank you so much. It's a big honor to be here.
Yes, thank you very much, Lawrence. It's a pleasure, as usual, to be with you here at the tower. With me in the studio, I have a medical and healthcare expert, Miss Dr. Joel Serubanja. Doctor, you're welcome once again to the tower at UNN.
Yeah, thank you, Dr. Juko, for yet again another opportunity to be able to share with our viewers on matters concerning health and Uganda. and I'll be very glad to interact with all of you on these pertinent issues. Thank you very much, Dr. Juko.
Thank you very much. Thank you very much. You're welcome all the time, and I think everybody is waiting for you for your deliberations. With me, I have also another healthcare expert, Mr. Barnabas Bwenje. Mr. Barnabas Bwenje, you're welcome to the tower.
Thank you very much, Dr. Juko. And I want to thank you so much for giving me an opportunity to discuss about the healthcare system back home in Uganda. It's everybody's responsibility to make sure that we put a big stone in making sure that the healthcare system back home in Uganda is put back to shape, and everybody benefits from that healthcare system. So thank you very much for granting me this opportunity, and I'm glad to be here on the tower.
Thank you very much. Thank you very much, Barnabas. It's a pleasure to have you at the tower, and I hope you'll be a frequent visitor like Dr. Serwanya has done. With me in the studio, I have Professor Kisitu, as usual. Professor Kisitu, you're welcome to the tower at UNN.
Thank you so much, Dr. Juko. I'm glad that again I'm present, and I'm so excited about this opportunity. Looking at the issue of health in Uganda, it is one of the most pertinent issues that we should always look at critically so well, and that everyone should look at very well. First of all, before I even proceed, let me first sympathize with those ones who have gotten some challenges in the course of the week. I just pray that may God heal their hearts, their bleeding hearts, and they get back to normal life. And again, I'd like to join myself to those families, those people, those groups of individuals who have gotten some wonderful things in the course of this week. May God provide them the best they have so far acquired. When you look at the other part of it, sincerely, I stand again to give my wonderful appreciation to the team that came up with this wonderful topic of health. I understand that by the end of this session, we shall have scratched down the ground to look at what health means. How are the people in Uganda surviving health-wise? Is it by the grace of the Lord, or is it by the too much work of the government? Or is it by the work of the doctors? Or it is just the gamble part of it, as the economy of Uganda is, that everything is by gambling. I'm so excited to be around this platform. I'm ready to provide the best. Thank you so much, the moderator.
Very much. Thank you very much, Mr. Chisitu, for that wonderful introduction. Generally, when we look at the Ugandan situation, Uganda is in a really bad state, for sure. Doctor, you must be a witness in this regard, because Ugandan situation is very, very worrying. Remember when we hosted you here during the COVID-19 situation, you expressed a lot of concern. Today, we're looking generally at the overall situation. In how is the situation in Uganda in regards to the health services? Can you wrap up that in around 2-3 minutes?
Dr. Jungo, thank you for that interesting or very serious question. The situation of the health sector in Uganda has not been good for a very long time. Probably we're talking about over 3 decades of having very big challenges in our health sector. And to make matters worse, that since 2020, we've gone through two COVID-19 waves, which further incapacitated our health sector. Okay, we were already crawling before the COVID-19 waves, and when the COVID-19 came, it broke us down more and more. Each sector of each part of our health sector is lacking. If you're looking at the human resource, we do not have enough doctors in in the country to cover the population. Okay, we have a doctor-patient ratio of 1 to 25,000. I'm going to say this again: 1 doctor to 25,000 Ugandans and counting. And even when you look at that enormous situation, you have to understand that most of the doctors are practicing in urban areas, and we're having the rural areas, the villages where there is abundant disease not covered by any qualified personnel. The ratio of nurses, one nurse to patients in Uganda is one nurse to 11,000. One nurse to 11,000 Ugandans, gentlemen and ladies out there watching. So whichever situation we want to talk about, in terms of infrastructure, we do not have enough health facilities. We have newly formed districts in the country, but if you ask where they are going to seek, the people are going to seek health care, you find that they're not traveling a distance less than 5 kilometers. I do not know where to start or where to stop when I'm talking about the challenges of the health sector in Uganda. If you're talking about financing of the health sector in Uganda, we're having on yes.
Let's first look at the general overall. The general, how is the structure? Do we have, like you've mentioned, we
Yeah.
have a ratio of 1 to 20,000 doctors. Do you have any information about the healthcare? I mean, the health centers. Talk about the health center 1, 2, 3, because people are not aware of what they are and what services do they give. How is the process of getting medicine from the medical stores to, you know, would like you to indulge deep into that.
Yeah, thank you, Dr. Juko. The healthcare system in Uganda has different players. We have the government healthcare system, and we also have the private healthcare system, where we have the private not-for-profit, okay, and where we have the private for-profit. Let me first expound on the government healthcare system. Nationally, we have what we call a decentralized healthcare system, okay, where we move from the most primary unit of healthcare, which is the village health team. Basically, these are members of the community that have been trained to identify those who are sick, to give trainings in the communities about disease prevention, basically to form the primary health care of the community. Okay, so the village health team is the first unit, primary unit in the Uganda healthcare system. Then you have a health center 1. You have the village health system is health center 1. Then you have a health center 2. Okay, this is headed by a nurse. Okay, so when a patient is identified by the community village health worker, they are referred, if they are basic, they have a basic complaint or issue, they are referred to a health center 2, which is headed by a nurse. So a health center 2 carries out outpatient department. The nurse is able to, do basic assessment and give what we call essential drugs. If she cannot cover the situation at the health center 2, then they refer to a health center 3. A health center 3 is headed by a clinical officer. This is a health cadre who has been with a diploma in medicine. Okay, they have more skills than a nurse. They can be able to dispense. They can be able to carry out minor surgical procedures. They can be able to identify more complex diseases. And at the health center 3, we have outpatient departments, and then we have also emergency medical care that can be provided at that level. We also have some inpatient. Health center 3, one can get admitted, but we do not handle complex cases at a level of a health center 3. Okay, I'm taking you through the system of healthcare in Uganda. So at a health center 3, if the cadre is not able to take care of the situation, maybe they do not have the skills or the facility, then you get to be referred to a health center for. So a health center for this one is headed by a doctor. Okay, in a district, a health center for is like the most general of hospitals. Okay, you can have emergency obstetric care for the ladies who are having difficulty in delivery. It has all the services of the health center 2 and health center 3. You can also get a blood transfusion at health center 4. And after a health center 4, then you go to a district general hospital, the district hospital. Okay, so you can see that from the very basic of the village health team to a district hospital, we are having a hierarchy of referrals, and you can be able to move from one part of the health sector to another depending on the complexity of your medical condition, and depending on what the kind of facilities that you need in a hospital. So from a district hospital, then we can go to a national referral hospital. Okay, we have Mulago as our national referral hospital. We also have Butabika as our national referral hospital. We have 2 national referral hospitals. Okay, so basically, that's how the decentralized health system is. Okay,
Then,
and
Dr. Joel, when it comes to,
yes,
would you also tell us the availability of medicine in this store? I mean, from the store to the hospitals. How about the pharmacies? What role do the pharmacies play? Can we also look at the medical side, the medicine side, the pharmaceutical
yeah. So
level side?
so thank you very much. So we are looking at we were looking at the government structure of hospital, but we also have the non-private, non-for-profit, where we are looking at the traditional religious-based hospitals. We have the Muslim Medical Bureau, okay, which has its own, Chibuli Hospital and Old Kampala and some other hospitals. We have the Protestant Medical Bureau, which has the, Mengo, and, we have the Catholic Medical Bureau, which has those traditional non-for-profit hospitals, okay? We also have, the pharmaceutical, the pharmacy side of the health sector, where we have the national medical stores that take care through which the government and its partners are able to equip the government hospitals and health facilities with the necessary medicines. And this still is at a decentralized level because a district makes known its health needs, it makes known its drug needs, its pharmaceutical needs by writing to the joint medical stores through its procurement chain, and pharmaceutical supplies are moved from the national medical stores to the district, and then from the district through the activities of the district health team, which is headed by a district health officer. These drugs are moved to the different health facilities within within the polity of that district. So that's how drugs are able to move from the national level, from the national medical stores to the lower health centers through the district procurement teams and the district health teams. And in the non-for-profit, we have the joint medical stores, which gets these drugs through the help of its stakeholders, the churches and the Islamic institutions, and then it's able to give to these non-for-profit organizations. So basically, in a nutshell, for the pharmaceutical side, we have the national medical stores. Then we have the joint medical stores for procuring and distribution of the medical supplies. But we also have the National Drug Authority. This is the supervising body to look at the quality of drugs that come into the country, to look at basically to look at the safety of the medication that comes in the country. So these different organizations and structure make the interplay that creates the health system. Not to forget the private clinics and the private for-profit organizations.
Thank you very much, Dr. Joel. That's a very good foundation that you have drawn for the discussion. Let me bring in Barnabas, Mr. Bwenje Barnabas, you seem to have, although you are out of camp of Uganda, you seem to be having great knowledge of the system because you worked in it, you were working as a medical officer. Would you please also tell us, what do you think uh, the system, how is the system, which flaws are in the system that you see in Uganda?
All right. Thank you so much once again, Dr. Juko, for this opportunity. Um, and I'm going to use the experience I had back home in Uganda and try to compare it with what I have seen here. But basically, I had a lot of interaction in Uganda because I worked in both private health centers and government health centers. So I have a feel about the two. Maybe before I proceed, I really want to thank the modulator for choosing the right word to give to the topic of today. Um, the Uganda health system is in a state of bewilderment. This is the best description of the healthcare system in Uganda. It's really confused, like we are lost. We It has no direction as we speak. Why do I say this? When we look at the healthcare system that is available in place in Uganda, it is one of the best models in the whole, I mean, in the world. We have models that are used in different countries, but I want to bring this out very clearly. We have one of the best models. If it is used very well, the health outcomes would be better. When we look at Uganda, where before 1980, the healthcare system was so dilapidated. I mean, were in the worst shape. When from 1980, that's when healthcare reforms were put in place. When these reforms started working, you remember that's the time when we got HIV in Uganda, and the infection rates were very high, and maternal mortality rate was very high, neonatal death was very high. So when we look at the health system, the policies that were put in place, they tried to bring all this down. When doctor was discussing about the structure of the health system in Uganda, um, he told us I can basically describe them into two. One, we have the national, and then two, we have the district. When we talk about the national healthcare system, we are looking at the national referral hospitals, like he said, Mulago, Butabika. Those are big hospitals. And then we have regional referral hospitals. These regional referral hospitals are supposed to serve regions. We have the Western region, the Northern region, Eastern. So those are also big referral hospitals. Then when we come down, he described very well the district model, which involves health centers 4, 3, 2, and 1, like he said. Now, the district model, which is used in Uganda, like I said, is supposed to identify problems within the community. And when these problems are gathered, diseases in the community, whatever problem that is facing the community, they are supposed to come up at the district, have meetings, and then identify all these health issues, and then make recommendations that are supposed to be carried down to the head, like to the uh, regional centers, and the regional centers are supposed to coordinate with the national centers, and then the problems are solved there and then. That is structure wise. So when we are looking at health center, usually we look at different parameters. Like I said, we look at life expectancy. What is our life expectancy in Uganda? As I speak, um, we talk about 62 years. So how we will see maybe some other discussants, what they talk about, how it is in the rest of the world. Then we are looking at maternal mortality rate. How is it in Uganda? we are talking about 43 mothers being lost in Uganda per 10,000 mothers giving birth. Then we are looking at neonatal mortality rate, which is around 18%. We also compare with the rest of the world. Then we are looking at skilled healthcare practitioners. We'll look at the trainings in Uganda. Do we have enough schools that are able to train medical workers? Do we have enough schools that are able to train nurses, so that we have quality healthcare workers who are going to provide the best health that the community deserves? Then we also look at malaria, which is in Africa. Here we don't have malaria, but we know it's a big burden back home in Uganda. So we also look at it, and we know there are many people who are still dying due to malaria. Then suicide is more common here, but it's not so common in back home in Africa and Uganda, because the rate is at 7%. So basically, in a nutshell, Uganda's healthcare system started, like I said, in a very bad shape. When healthcare reforms were put in place, we started gaining some momentum. But as I speak, because of different disparities that we're going to see, we'll find that the system is like confused, totally confused, because if you look at people who visit health centers, we are talking about government health centers, you realize that most people start with clinics. Maybe they go to seek for medical care from clinics, private clinics, and if they can't afford the bills, like we are going to talk about how expensive medical bills are back home in Uganda, we will see that if people cannot afford paying for bills in private clinics, that's when they end up coming to health centers. But there are very many issues they face, definitely, in health centers. Like he said, lack of medicine, then human resource, even the human resource that is there, they are unprofessional. They are so rude, and this ends up sending away people from coming to seek for medical services. So he also highlighted on what is used in the hospitals and health centers, the equipment, the medicines. I want to inform viewers that we originally had two models of delivering these logistics in hospitals. We have the push system and the pull system. The pull system is where all health workers sit and plan. They say, we need, maybe in our hospital, we need this number of medicine, this number of tins of maybe paracetamol or whatever medicine they need. And then they come up with a list and send to, like I said, to the structure, the system. They send to health center 3, health center 4, health center, then hospitals, and national medical stores, maybe, which is the overall. So that whatever they have requested for is what national medical store will end up sending. That is the pull system. Whereas the push system is whereby national medical store identifies what they have in their store, and they say, now we're going to start distributing health centers without asking what they need. They just pack boxes and say, let's take to Rukunjiri district, for example. Then we distribute among health facilities. But when we look at the two models I'm talking about, one is discouraged. Why? Because, like, you know, everything has its advantages and disadvantages. When we look at the push system, we realize that medicines are sent to health centers, boxes are sent, but because they are not in need, they will end up not using them. So what happens? That's where you start hearing that drugs are expiring in health centers because they sent them, they don't need them, and they end up expiring. So the best option here would be the pool system, whereby people sit in their respective health centers, plan for what they need, request, and then it is sent so that it is efficiently and effectively used in these health centers.
Thank you very much. Thank you very much, Barnabas. Thank you very much for that effort to explain, because it's really very not very easy to expound on the very structure that Ugandan healthcare is in. Let me bring in Lawrence. Lawrence, let's look at how do you compare the system that Barnabas and Joel have talked about into the global perspective?
Well, thank you so much, Dr. Junko, for once again that question. From a global perspective, I think every geographical location has its own challenges, and they all have a way of coming through to close whichever gaps they're having in their healthcare system. So if I may just look at just a few top countries that are leading us in terms of maybe physician numbers around the world. Just one moment, please. Sorry about that. Why did I put this? Wow, this information is all over the. Oh, God. I think I lost my slide right there. So basically, I think let me just start off from what is existent, I think, down here in the United States. I think we've heard a lot from fellow panelists about what is happening in Uganda. So the US system is probably more organized, I could say, and of course very centralized compared to what you have down there in Uganda. So we have a bunch of components that are within the healthcare sector, as you can see on the display right there. So you have health providers, of course, that are broken down into those four major blocks, which are the hospitals, ambulatory care, those handling mental health and substance abuse, and of course you have the pharmacists coming on the other side. So each of those domains, of course, is handling a specific need in the population, and this is on a state level, and more so even on the federal level, which is a national level again. So under the hospitals, you have, of course, federal hospitals and community hospitals. Then you have the non-federal hospitals, which could be private. And then under community, you have those for profit and those that are not for profit. That cuts into what we have as the church-founded, probably hospitals we have all over the country. So as you can see, the components are very well, at least, aligned with the society they're trying to serve down here. But getting deep into how these interact on a national scale, it's rather very interesting. So you have the way people access healthcare basically here is through having some form of insurance. So insurance goes hand in hand. Health insurance goes hand in hand with how you're going to access healthcare for the most part. It's not that you cannot access healthcare if you opt out of insurance, but the problem is it's going to be very expensive for you. So it makes all logical sense for you to actually have an insurance cover on that note. So as you can see, you could access it either through the state, privately. State if you are unable to afford healthcare, that is to say. So that cuts into medical aid, Medicare, Medicaid. Those two are able to provision you healthcare insurance in case you cannot afford it. And of course, that gets back to how do you access healthcare. It's based on your eligibility. Here, it is just basically if you're a citizen, or not necessarily a citizen, but your immigration status. Sorry to say that. Whether you were a citizen or a non-citizen, you're still entitled to healthcare. So anyone should be able to access it. And then, of course, the other one, the other criteria they use to afford you or give you healthcare is where you stay, the residence. Of course, that would zero it down to which area, geographical area, in terms of the state. And different states have a different way of approaching healthcare. But it's all aligned, like the way I showed you the components they are, the same way across the board. So it's not like when you go to Texas and it's very different from what you're going to find in Alabama or that. So the eligibility is to just go to how you afford, how they accord you healthcare. It's based on how much you earn, your income. So depending on what your paycheck gets you per week or per month, here because it's usually per week, that is able to afford you a certain package. So if you earn a lot more, if you earn beyond certain points, because they have points that allocate to your income, then you can access free healthcare. That is, if you're earning very little. And of course, if you're earning a lot more, then they expect you to pay for your own healthcare. So looking at that, depending on where your income is, it's not like it's a universal kind of system that everyone has to fit into. No, it really varies on how your economics, your personal economics is faring. So again, you can in this they've tried to structure it to cover the everyone, depending on where on how their livelihood is, because they need you to keep enough money to pay to other aspects of life, because it's not just about health, but they need you to be healthy. So they will still cut your package to afford healthcare in case you need it. Moving on, if we're to just look at, I think the ratios that the doctors were, Dr. Joe was talking about, and Dr. Barabas, you talked about the patient to doctor ratio and the nurses to patient ratio. And it's quite interesting how that one pans out here, because I think for the physicians in the US, you're looking at one physician per about 300 or 400 patients, which is yards away from where Uganda is, which is about one doctor or one physician to about 10,000 or 20,000 patients. That is really, really wide. You wonder how the doctor can keep up with all these number of patients all together. So, and then when it comes to nurses, it's even more interesting. The ratio is way smaller. I think the widest we have is, or rather, for trauma and ER, you have a 1-to-1 ratio, so one nurse to one patient. You can see that. And for nurses, I heard for Uganda, it was a little, of course, high as well. One nurse to, again, still over 10,000, which is, I wonder how one nurse can really pay attention to this number of patients. And this is why you can see that in most cases, patients or people who fall sick back home are forced to bring their relatives to do the nursing part, because the nurses are actually not available. Or in some places, they're going to be playing the part of the physician in case the doctor isn't around, or his shift is done, or he has to go to another healthcare center altogether. So basically, that's just a simple overview of to give you a comparison of how healthcare is aligned out here in the States. And I think I'll make to submit at that point.
Yes, thank you very much, Lawrence. That's a very deep into the other sectors. I mean, the other healthcare systems in our various countries. Let me bring in Mr. Kisitu. Professor Kisitu, I want you to express and give us a deep cut into the system and how it looks like, especially with you who is in Uganda.
Come again, please. Come again, please. I'm sorry.
Let me bring in Mr.
Can someone help me
Barnabas.
to understand what the doctor is saying?
Yes, Mr. Barnabas, I think we need to, you talked about the problem that we have that needs to be really examined. Let's look at other medical services, because he talked about those non-government organizations. He talked about the facilities that are owned by religious people. And how do you, what is the funding? What is the way that money is funded, those institutions are funded, and how do they work? Do they work for free, regardless of, or they do charge money? We seem to have lost your sound. Can you unmute yourself?
Oh, sorry. All right.
Yeah.
I think you can hear me now. Yeah. So when we look at the health care services in Uganda, one would wonder who pays for the services, and do they actually get value for the services they pay for? That's the first question that comes into people's mind. So when we look at the cost of healthcare system back home in Uganda, is it affordable? I mean, do people afford these services? And the answer is definitely no, because when we look at um, the system, I mean, living standards of Ugandans, we realize that the biggest population um, is poor. Basically, people don't have money for basic needs, food, shelter, health, education. So in general, when you look at Ugandans, the biggest population, that is around 80, or if not between 70 and 80%, people are poor. They don't have um, money to pay for medical services. What eventually uh, this leads to people not obtaining the services they require. So, like we said, there are private medical practitioners that are supplementing the healthcare system in Uganda. So, everywhere worldwide, I mean, countrywide, we have private clinics and we have hospitals that are non for profit. They don't, well, they make some little profit, but they don't really make a lot of profit. So in this way, they get some little support from the government, and this support um, helps subsidize the prices. I mean, the rates at which people pay for their bills when they come to these hospitals. But like we know, most private clinics, definitely they are not supported by government, and therefore their bills end up shooting, and poor Ugandans may not afford to pay for these healthcare services. So basically, when we look at those who afford, people who have money, and we know that they live around towns. Talk about Kampala, talk about surrounding areas, Wakiso, and the other districts. That's where we have the wealthy class, people who are a bit well off. Uh, they can be able to work, they earn a living, and they are able to pay for their services. And that's why you find that, again, we have a big number of private health practitioners around those areas, big towns and big cities. So here, rich people are able to pay for their services. But when you look at the biggest population, like I said before, which is living in rural areas, they are poor and they are not able to pay for their services. So um, one of the uh, one of the speakers here talked about health insurance. I'm glad he brought it out. Um, when you look at health insurance here, it helps everybody to access medical services, which is good. I mean, whether your status is okay in terms of uh, uh, whatever status you live for here, you're able to access health services. But back home in Uganda, uh, when we look at health insurance, that is an idea that was put before Parliament, and it has never taken a good state. But we, when they tried to put it in place, I think there was a lot of resistance and it was not effected. But when we look at, there was a survey made in Uganda some years back. Actually, it was not a survey, it is kind of a study whereby they chose specific areas and they started some health insurance, some little health insurance. So they get people in a local council one, for example, or council two, and then they start picking money from them every month. They contribute a little money, which is put together, and eventually it is used when these people fall sick and go to hospitals. Eventually, this is the money that is used. Actually, some of the outcomes show that there was a very big improvement in the people seeking for medical services, and and because of the availability of this money, people were able to go and seek for medical services, and they were able to obtain these services just because of the little money they have been contributing for over time. So that is sort of an insurance that was supposed to be enrolled countrywide, but it never happens. Like you see, yeah, like you see, we have challenges of not putting into research results in Uganda. People don't put the research results to use. And when you don't put research results to use, it will end up being useless. And then there's no improvement in the healthcare system. But had they enrolled this healthcare insurance scheme countrywide, I think we should be getting more benefits from it, and most Ugandans would be benefiting from it. But because there is no insurance back home, people are poor, they are not able to pay for their medical services, medical bills, they are not able to meet medical bills, so they end up not receiving a good health care in the way they're supposed to be getting it.
Thank you very much, Barnabas, for that kind of submission. It has been really very. I bring in Mr. Kisitu. Mr. Kisitu, you seem to be very well versed with the system because you're part of it in Uganda. Would you please dig us deep into the system, the healthcare system in Uganda?
Thank you so much, Doctor. Looking at the health sector in Uganda, sincerely, I could say that we deserve a prayer. And everyone in whichever corner of the world where you are, please, I just request that you spare a second and you pray for your country, Uganda. Uganda is bleeding health-wise. Uganda is soon dying out health-wise. When you look at the health systems in Uganda, infiltrated. Health systems in Uganda are diluted. Health systems in Uganda are counterfeited. And therefore, they cannot deliver what is required. Currently, as we speak, Uganda is estimated to be having a population of over 45 million people. Based on the reports that we've received the course of this week, birth rates have increased, given the fact that young children, many of them have been out of school, and what they have resorted to is getting pregnant and conceiving and producing children. But when you try to look at how they're going to survive, indeed you ask yourself a lot of questions. Healthcare systems in Uganda are so bad. Why? They are characterized with the following: 1, corruption; 2, tribalism. Then the other is lack of enough materials in all the health centers that the doctors talked about, starting from the village health team having only a bag having paracetamol in it, which is given, I think, for first aid. A person, a VHT on the village, who even doesn't know how to detect the critical conditions within a patient. One could argue that that is not his or her responsibility, but at least someone that the village can refer to, such that he or she can handle some of the complications, must have some knowledge. That is why when we were in primary, we had the general science, which looked at all the aspects that refer to health. And I personally am not a doctor, but at least I picked some things from that. But the VHTs are totally having nothing as far as the part of it is concerned. Center, a nurse whose the ratio is 1 to 11,000 people. That is again a little bit so tricky, and I don't know what is the challenge there. When you look at the health center 2s, 3 and 4 that the doctor talked about, I'll give a live example. One time I went to health center 3, is it 3 or 4? That health center at Kasanga. One time, as I was still saying that side, I went there. I wanted to check whether I was suffering from malaria or typhoid or any other complication. Then I was given a task to go into a certain room to meet a person who was in the room to buy gloves. And this person was like, we don't have gloves, but you only need to pay 2,000 Ugandan shillings, such that you can access the gloves, and we check how. Yes,
we have some problem with your Mr. Kisiri network.
I can go on.
Let me bring in Lawrence. Lawrence, you had a point that we are trying to drive to. If you look at the system as Mr. Boyenge said, it seems like the system, our structure is one of the best, but the problem seems to be with implementation and supervision. Would you please look at that as well?
Well, thank you so much, Dr. Juko. I did get into a few technical issues earlier, but I think that I have tried to overcome. So the other aspect I wanted to talk about is probably how healthcare is kind of delivered, or the application process to get coverage of some sort. Because here, healthcare is one-in-one with insurance. This traces its history back in the 1920s when that discussion started off actually in the 1970s. Yes, there was still rather the 17th century. Sorry about that. I keep mixing up the dates. When some form of health insurance started off in this country. So you can see as early as 3 centuries ago or so, the US was already seeing how health insurance can be, can come as a silver bullet to save its population and look after its people. But I think it gets more traction when it comes to the 19th century, which is the last century, in the 1920s, when they start to roll it out and see how everyone can actually be part of this. So I think they started off by the Baylor University, where that's in Dallas, where they tried to offer healthcare for the teachers in there at that time, and it was just costing them as little as just $6. And that is how the Blue Cross health insurance plan actually gets its inception into the provider's portfolio. So looking at that, and I think $6 was probably not very little money even then, but at least there's some will to be like, this is a real concern. People can't exactly pay, for these bills on their own. We need to form, or rather come up with some kind of arrangement that can be inclusive, that people can actually access healthcare. So for countries that are doing it probably better than us, you can see the kinds of steps they are taking towards saying that healthcare is accessed by everyone regardless. So coming on closer to, of course, there were a number of undertakings in between there until all the way to the 2000s, when I think the Affordable Care Act came in, which is more commonly known as Obamacare. It comes in now to now also include, because initially you had to pay, they were like, now we could include those people who also can't pay. So you can see the system is evolving with the needs of the people it is serving. So it is not like everyone has to pay, even those who couldn't. But because if you look at the bills, I think we've had so many instances, especially back home in Uganda, where someone is going for an operation. This, I think, is probably everyone's personal experience, and then the whole family has to come in because the bills cannot be, the patient cannot exactly afford their bills, and there's no help coming from anywhere. And of course, insurance is still giving our people a bit of a challenge, because they don't want to enroll or rather consider it. People feel like they're just giving away the money for free. But the day you get up and then you have this operation or surgery that you must have, that's when you realize that maybe the 50,000 or 100,000 you're paying every month was maybe worth it. I'm not saying that those should be the figures, but I'm just trying to highlight just an example of how much probably people would pay. But that compared to how much people have to raise when they have to go do surgery, maybe in India and all these other places they go to, it's rather it would be better if people just considered health insurance on that note. Now, just looking at how, for instance, if you were to come just to the state of Massachusetts, how it is done, I told you it's based on eligibility and your residence where you stay, and of course the other point is your income. So Health, in this case, you're going to throw in an application, and this is all done online. So you don't have to go to any location necessarily to have to access health insurance or healthcare facilities per se. For starters, you can start the application online using the Mass Health application portal. And that interacts with a good number of other systems in the background. And just to give you just a little bit about what happened on the technical side, I think when these systems were rolled out in the first place, they actually crashed because everyone was trying to access them at the same time, and they could not handle the load. But all those have actually all those gaps have actually been closed off, because the databases were big. There were so many requests they are getting at the same time. They had hell, trying to roll out that system initially. But all that has been aligned with the needs and the numbers they are holding right now. So you're just going to put in what your status is, your income, and where you stay, and then voila, you're into the system. They'll contact you and try to verify and whether this information you're giving is exactly accurate. So you could lie on your income, but then they'll be able to tell whether your income is actually higher and you're not supposed to be accorded, free insurance. And even if you did eventually, when it comes to filing taxes, you're going to be penalized if you access you access the free service, so you didn't spend money. You still have to spend that money, release it when it comes to taxes. So it's just aligned that way down here. And for me, I feel that any country out there that's really trying to improve its own healthcare, they could just pick it from how countries like this, like the US, have done it. You don't exactly have to do it exactly the way it is here, but there are some aspects you could pull. Like, for instance, getting the application to insure everyone online. You don't need, to have a stampede on all these healthcare facilities we have in the country, the VHTs like you've talked about, and all those. And you're having the whole village show up just because you're going to document that they're interested in healthcare. We can always leverage on technology. And for me, I feel like this is always just the limitation, or rather, something we ignore in our countries out there that may be on a less developmental path than these. We ignore these technologies, yet they're the ones that are supposed to give us the leaps that we need. So as you can see, just moving on to maybe how much of the GDP these countries actually spend on their health insurance, it's enormous. In 2018, they were at about 17%. And it keeps going. You can see it's growing right now. It's about 18%. In about another 5 or so years, it's going to be close to 20. So the country is committing that much money to make sure that its people are, are fine, they're healthy. And do not be deceived that this only just shows. I know that people who interpret these results to show that, the US is a very diseased nation. Yes, we could say people are diseased, but at least they're doing something about it. Please mind that this is the money that is paying for all those doctors and physicians that you saw. You already saw the ratios. In some cases, the nurse to patient ratio is 1:1, 1:2, 1:5. Someone needs to pay for that. So a country committing that much, it's making sure that its citizens are employed. So you're solving two problems at the same time. Your citizens are employed, and on the other hand, they are accessing the best healthcare. So, and by this, they're all trying to make sure that the citizens are healthy and they can keep working and developing the nation. So when it comes to us and we're not paying attention to healthcare, we're losing a lot of talent. There's a lot of useless loss of life out there, which could be avoided if only we took the initiative to try to emulate what places like this are doing. I don't have the figure of head for how much of the GDP Uganda actually spends on health, but I am quite sure it is less than what for instance, the US is doing. On that note, it's of course now back to you. What you think? Does this make any sense, or is this something we can do? I think we can do. So I beg to submit. And maybe something that I just left off. Sorry, one moment. That other screenshot came up from my producer about the healthcare spending. You can see those are actually very interesting figures. Just look at how much that translates to right now. It translates to about 2.8 trillion. That's how much healthcare is, you're spending in the US. And it's broken down as to how much exactly goes to the providers and all these other these other places. And how much insurance companies are chipping in of that. Those are good figures, you can see. Medicare and Medicaid, I think those are the free services in there. And they're also spending in hundreds of billions, to make sure that people access healthcare. So you're spending money on something that you need that is supposed to keep your people healthy. We can always pick a leaf from these people and then, try to do the same. And maybe we can be able to reap the benefits of having healthy lives. Thank you, Doctor.
For sure, you keep you can keep a leaf or pick a leaf from what they are doing, so that we can also place it in Uganda. Uganda needs to be directed that way because really our people are suffering. Let me bring in Mr. Kisitu here. Mr. Kisitu, I want you also to go a little deeper because you have an experience and a feel of Ugandan situation. Would you go ahead, please?
Yeah, thank you so much, Doctor. To look at the health care, the health system, there's a lot of corruption, tribalism, and people, the doctors not being on duty. And still, when you look at the way how the medicines are being given out to the patients, still there are a lot of gaps in Uganda. What I'm talking about is what I've seen. Today I've been to the hospital of Kasanga. I have my friend who was operated and was just about. The hospital cannot manage to have such a simple thing that can be of very much importance to make sure that the medicine is very well injected into that patient. Still, getting the medicine that you need is not always at your disposal. The doctor can prescribe, and then you're directed to go somewhere else to buy the medicine. I don't know what the challenge is. I don't know where the challenge comes about. But sincerely, we should, I think, in my opinion, the government of Uganda is controlling a lot of things. You cannot be the very person controlling defense, controlling citizenship, foreign nations, telecommunications, electricity, interregional highways, dams, railway networks, and so on, airports, and so on. And again, you also take into account the control of the healthy part of it in the country. There are some issues which must be left to the regional level such that people can acquire the best service. Health care is one of the basic things that one must have. And the world should know that health care, education, feeding, clothing, and accommodation, they are one of the basic primary needs which the government is supposed to provide at almost a zero cost. But in Uganda, nothing is provided at that. And sincerely, people are dying, people are suffering. I've tried to move around Uganda. When you look at the Greater Rural, where we had a lot of issues with the government, you would find out that the hospitals and the other center tools that are there, they don't have the medication. They don't have the medicines that people need on the ground. And people have ended up living a lifestyle that is not all of that appetizing. And sincerely speaking, a lot has to be done to make sure that at least there is, what is wrong with my system? That at least there is improvement in the health system. If you try to move around Luwero, there is Katikam South, Katikam North, where they have only Bombo Referral Hospital. And this hospital was meant to be for the soldiers, was meant to be for those ones who have been in the battles fighting. But you find out that people that side are using the hospital to make sure they're medicated. And at the same time, there is competition with the soldiers. So it becomes tricky. Other parts of Ruwero, they don't have even the referral hospital in the region that you can even refer to, but they claim that there is a Chiwoko, which is even so far. So when you look at the population in the region in relation to what we sincerely need, things are not matching so well. And we are still relying on the hospitals or the medical facilities which were established by the colonials, the colonial masters by the time. Today, if you ask of how many medical facilities are established by the government, you end up only counting them on your fingertips. You look at Chirudu, and these days they are saying that whenever you're taken to Chirudu, just be sure that you're visiting your final destination. You look at this hospital in Kawempe, which is doing some good work of making sure that, that our mothers always give birth very well. But you find very many of them flooded on the ground, flooded on the floor.
Let's go for a break as we try to discuss furthermore, because we have some technical issues. Let's have a break, and then from there we shall come back and then dig deeper into the discussion.
Time takes a toll on everyone, they say. Time is merciless, it won't wait for us to change. Time, I am stressing out, I can't figure out what to say. Oh, time, just give us time. Time, looking back on pictures, and I find it hard to see you and myself in places where we used.
Welcome back once again, the last part of our show today, as we discuss these problems that we have in the health, trying to look for the solution, and then after which we shall, try to see how applicable it is in Uganda. With me in the studios, as mentioned, I have Mr. Bwenje Barnabas, who is a medical expert, and I have Mr. Lawrence Semugoma, and I have Dr. Joel Servanja, who is a medical doctor practitioner in Uganda, and I have Mr. Kisitu, as usual, our discussant. Right now, let's look at the issue of the challenges. What are those challenges that people in Uganda, or the medical service people, or people that work in the medical service, have that have failed them to do their job? And what remedies can we have for them that can help to cover up? Look at also the remedies that we can give to our people, especially those service users. How can they access all this? Let me bring in Lawrence. Lawrence, given the experience that you have with Uganda vis-a-vis American system, I want us to look at those challenges that you look, which are from the dimension of the medical suppliers, or this medical service suppliers, and then look at also the receivers. What are the challenges they have? Yes, Lawrence. Okay, I think let me bring in Barnabas. Barnabas, given your experience in Uganda, there are a lot of challenges. Look at those challenges, and then let's look at them in terms of the people who are receiving and those that are giving services. Yes, Barnabas, go ahead.
Thank you so much. Once again, when we look at the challenges that are faced with the healthcare system in Uganda, some of them can really be worked out in order to improve the healthcare system. But before I go to some of the challenges and how they can be worked out, I wanted to let viewers know that the money that the government of Uganda spends on healthcare system is so low. Yes, the parliament has tried its best to make sure that financing for health in Uganda has increased, but it's still insufficient, because the government spends US dollars, 14% per capita. That is very low. And you find out that $9 is out of pocket, then 5 from public sector. I mean, when you look at the money that is spent, right from the government, and then people, money that people have to pick from their pockets, pay for the services, it's a lot of money versus what government provides. Uganda is one of the countries that signed the World Health Organization Abuja Agreement. And this agreement was bowing every government that signed to spend at least 15% of their national budget on health. But you guess what? What's happening to Uganda? Uganda is spending between 7 and 9%. That is well low. If you look at the national budget and you're spending 7 to 9%, it means that healthcare financing is so inequitable in Uganda. So we really need to make sure that government puts in more funds, need to raise the fund of the healthcare system in order to eliminate some of these problems we are talking about. So some other challenges that we talk about, we are looking at human resource. For example, Mr. Chisitu talked about visiting a health center and you find maybe there is a doctor or there is a nurse or somebody to attend to you, but they don't have what to use. They don't have medicines. They don't have gloves. Our dear viewers, talking about these things, sometimes we talk, I mean, it's like these things are not real. But I was working in a national, a referral hospital back home in Uganda. Dear viewers, healthcare workers in Uganda need prayers. Sometimes you're going to deliver a mother, but you don't have gloves. The only option is to send this mother to go and buy gloves. If they can't afford the gloves, then I wouldn't use my hands to deliver this mother. So basically, these things, we talk about them and they are real and they are there. So our government back home really needs to do a lot to make sure that some of these logistics are in hospitals, because it is one thing setting up the healthcare system. You build health centers, like we said, you recruit human resource, and then if you don't give them logistics, they will end up not delivering the health services that the community requires. When we look at human resource for health, dear viewers, we know that there are many schools that have come up in Uganda today, and they are training health workers. They really train them very well. But you know what? What happens when they are trained and they are not absorbed into the system? They are not going to provide the services they are trained for. Most of the health workers are running out of the country. They are going to Kenya. They are going to everywhere, worldwide. Rwanda, like we talked about insurance, in Rwanda, actually, the neighboring country, they have implemented the health insurance scheme, and they are doing very well. So they are able to pay their health workers. They are able to bring logistics in the hospitals, which would be a very good lesson for us, Uganda, to benchmark and see how we can improve our health system. So we train very many health workers, but we lose a lot of health workers. So when you are putting water in a basket, water is flowing out, you'll never fill the basket. So we are training health workers. There are many training schools, nursing training schools that come up. They are training nurses, but they end up leaving the country for greener pastures, and then we end up having no human resource for health. Talk about the services that are provided. Well, we have health workers who are in hospitals, but like I said earlier before, they are rude because of maybe the workload. By the time the patient comes in, a doctor has seen 100 patients in a day, and then he's impatient, he's rude because maybe he's not being given the rightful payment, they are underpaid. I mean, there are many things that are surrounding. So if this doctor, if this nurse is rude to the patient still won't get the services. They will fear going to hospitals and clinics and health centers because the health workers are being rude to them. Then when we look at the distance, dear viewers, many people in Uganda still walk over 50 miles to seek for healthcare services. Some mothers deliver along the way. As they go to seek for healthcare services, they end up delivering along the way because the distance is so long. What do we do? I mean, yes, the government has tried to put in some areas some modes of transport, but still they are not enough. If, for example, a health center is given an ambulance, this ambulance needs a driver, it needs servicing, it needs fuel. But guess what? Like the ambulances that were given during COVID, I guess they must be rotting in health centers down there because they are not serviced. If they are serviced, they don't have a driver. If they have a driver, they don't have fuel. And they end up telling patients, please bring money for fuel. Poor Ugandans, they don't afford, they don't have the money for the fuel. So what happens? Again, we have issues. When we talk about the waiting time, it's also still a big problem. When patients go to seek for medical services, they overwait. They wait for so long. Maybe the queues are so big, or maybe the doctor has gone to do some other private job, or the nurse has gone to do another private job, and they will come to attend these patients later at their convenience. So what happens? Eventually, the patients are not satisfied with the service because they come and wait for so long, and the next day they wouldn't want to come back to the health centers. Okay, so all these challenges combined, they end up making healthcare seeking behavior so difficult, and people end up not getting the services. So I don't know whether you want us to discuss some of the remedies that can be brought on board. Yeah, yeah. So like we are saying, we have talked about financing. The healthcare system needs a lot of financing, and then we need motivation. Motivation in two types. There is I can call it internal motivation and external motivation. When we recruit these health workers, or if we have human resource in a facility, how do we motivate them? First of all, we need to make sure that we instill a spirit of professionalism. These doctors, these nurses need to be need to be all the time being appraised in terms of assessing their performance, and then ensuring that they have professionalism in the work they are doing. Usually, there is what we call continued medical education. I wonder if all health centers have this. This is a program that is meant to make sure that doctors and nurses and all health center staff keep revising and getting new knowledge, new skills, to make sure that they provide quality health services. Then we also need to ensure better management. Do we have enough human resource that is trained very well to make sure that they lead these teams? For example, if it's a health center, do we have a good manager who would be a doctor? Some people think that studying medicine, you become a leader by default. No, that's wrong. If somebody is trained to be a doctor,
Actually, Barnabas, here, when I was doing my master's in business administration, I had doctors in business administration. Actually, I had engineers. I had a lot of other people from different professions. That's how they do it here.
exactly.
Go ahead.
So if you have a doctor who qualifies to head a health center at a district, you need to train this doctor to give them a skill in management. Otherwise, they will lead a team and they won't lead it very well if they don't have good managerial skills. So that
Thank
is
you
one
very much.
that really helps to improve health. So the other external motivators, like I said, we have people who should monitor. We are lucky in Uganda, we have very many non-government organizations that carry out research. They need to keep coming in and making sure that all the time there is quality being implemented at all levels, be it health center 1, health center 2, health center 4. Quality must be ensured. We must check ourselves all the time to make sure that if we are looking at a certain level of quality, whatever we are doing, we must compare and see at what level are we. Can we be able to reach that level where we need to provide quality health services that deserve to be given to Ugandans?
Thank you very much, Barnabas. Thank you very much for the the labor they've made to discuss this. As we try to, let me bring in Mr. Kisitu. Mr. Kisitu, I think we need also to look at the challenges. You as a teacher, and in particular, I want you to dig as looking at the remedy, the problems or the challenges that we have, and then look at the remedies that we can put across. Go ahead.
Thank you so much, Doctor. To look at the remedies or the solutions that are needed, such that we can make sure that we can rescue our health systems in Uganda. The first one that I would highly look at is improving the recruitment process. Always the medical officers are recruited and they are posted in regions which are not geographically friendly to them. For example, a doctor will tell you that a doctor who grew up from Masaka is posted at Kalangala to go and work in Waters. And this person feels like will not go and work that side. Goes only once in the course in the month, and patients still suffer. So the recruitment process should be improved. People from a region should people who are bona fide citizens of the region, the doctors of that region should always be put in that region such that they can provide services because of the fact that they are used of the geographical environment of the area. Then the other is improving the infrastructure, the health infrastructure, starting from the health facilities themselves to the housing facilities of the doctors, such that doctors could feel very comfortable at the workplace and without having a stress of where they will be sleeping. Currently, when you look at the housing facilities of the doctors, sincerely, they are so bad and they are so poor. Critical illnesses, critical conditions should also be looked at critically so well. They should be nationalized. Let the government take up the responsibility of treating the critical conditions within the patients. Like how the government takes up the control over the pandemics, let it also do the same thing to the critical conditions or illnesses in the patients. We always look at the mothers who give birth to the children with complications. And when you look at the level of income of the Ugandans, of a normal Ugandan, sincerely, this person is not in position of catering for all the expenses that are needed. You find out that those patients move to the media seeking for help. Yet the government can get the funds to help fight against such a condition. Then still let the health part of it in the country be regionalized, such that supervision is strengthened. The central government cannot supervise all the systems from one point. Let the systems be regionalized in as far as health is concerned. All the medical materials that are needed, the gloves, the syringes that are needed, the medicines, let all of those ones be provided on time. And sincerely, the fringe benefits should be given to doctors, appraisals, praising them for what they are doing. On top of that, emergency transport systems should be prioritized in the country. I can give an example, and a vivid example. Rural district, looking at one of the constituencies, that is Katikam South, which has almost 4 sub-counties. It has Bombo Town Council, it has Nyimbwa sub-county, it has the other side of Makurubita. As big as Makurubita is so big with very many people, and again, look at Katikam side of it. The area doesn't have even a single ambulance, yet it has very many people. The roads are so bad. It is the politicians who always come up to put up ambulances, claiming that they are theirs, and indeed they are theirs, to help in the handling of emergency cases within the patients. So the government should provide the emergency transport systems in all regions of the country, not only in Kampala, but also in the villages, to ease that. On top of all of that, we need fresh heads in management of the country, Uganda, because the management that is available has proved itself that things cannot go on so well, because we have over and again talked about these issues, but nothing is changing. This is going to management, such that the above remedies that I've talked about.
Thank you very much, Mr. Chisitu. Thank you very much. We seem to have trouble with the network. Let's try to wind up. Let me bring in Lawrence. Lawrence, I think we need to look at it in terms of how the characteristics of a good healthy system, which is being cost effective, affordability, satisfaction, availability of resources and accessibility to it, and then reliability, how reliable it is. Would you please look at the challenges in relation to those characteristics, and you give us remedies for this? Yes, Lawrence.
Well, thank you so much, Dr. Nadine, right there. Indeed, you make a good point that yes, characteristics of a good health system is that it should be accessible and it should improve lives, because that is the main reason you have it, to keep people alive and such that they can go about with their livelihood and achieve their goals. Of course, we've discussed, in comparison to Uganda, what is happening, in so many first world countries. You've seen what happens here. It is systematic. It has all these components. It's, customized per geographical area, which is what Mother Chisitu was just talked about, which is per state. So coming back to Uganda, I think there's a lot to learn from people, or from places like this, as to how we done better. Can we really conclusively say that healthcare is accessible in the number of beds we have, we need? And of course, of recent, you saw the call out by the president to have most teachers more. More people into that area, and then maybe they will take up medicine and pharmacy. But do remember that while you're training most of these people, it's not guaranteed that they're going to work in the. If they are trained and they feel that they do not have access to the equipment they need to use in Uganda, they're going to have to travel at the end of the day to other areas. So, and this is, of course, the challenge of going about this issue that way. you might think you're solving one issue, and then you end up finding that whatever attempt is not going to get your problem away. But again, it's a chance we can take. We can try and see if we can encourage more people to get into that domain. That maybe it is going to improve things in a way. And of course, if we can have more access courses, because the issue of accessibility, how do we get more nurses in and doctors in? Can't we have other courses, easier courses that people can do in a few months, as long as they have a certain basic level of training from the system? Maybe they are senior 4s or senior 6s, and they have at least done sciences. Those are easier to put into the medical field as nurses, and getting into these small specialties, within healthcare. That would help broaden the base and bring in the manpower that we need, such that we can have more coverage. A ratio of 1 to 10,000 is huge. It doesn't in any way give confidence that we are actually looking out for the health of the people out there. However, spending too much, like the way you've seen for the case of the United States, I think it spends way too much compared to the rest of the world. In some cases, even doubling some of the expenditure that other first world countries are using. However, that doesn't necessarily it is a healthy country out here, or like it has the best healthcare. Surprisingly, right now, the best healthcare is actually in Denmark. It's ranking #1 as of last year. But again, looking at Denmark, you have a population of just about 5.8 million people in there. And then you have Norway, which also has about 5 million, Switzerland, and it goes down to Sweden, Finland, Netherlands. You can see all those are within Europe. Europe seems to be leading the way with healthcare systems in the world. And yes, believe me, they are not so different from what is happening even in the States. It's just the way they are rolling it, making their people have access to good healthcare. But one thing you should note is that their populations are actually very low. So the country with the best healthcare system actually has one of the youngest populations in the world. It's just 5.8 million. Now, looking at that, Uganda is at 40 million, and they told we also rank as one of the countries with the highest fertility rates. We're adding 1 million to that every other year. In a few years, the facilities are not checking, or the infrastructure is not checking, apart from maybe the roads and all those other. But the healthcare facilities are not at the rate at which the population is expanding. So the ratios, I'm afraid, might actually expand. If you look at, I think it is, I don't know whether it's within the Vision 2040 or the other one. They estimate that the population is going to be close to 100 million in a few years, maybe 20 or 30 or so years. If you have 100 million people, how are we planning to have the healthcare systems come in to move at the same pace as the population is growing? If we are not doing that, then yes, we're going to keep being a disease nation, and of course we're going to have to increase immigration figures such that people can go out and access these facilities out there. And this you've, I think, witnessed with the way different classes of people approach healthcare issues in the country. For instance, if a minister, like I think the last time we had a good example here was the time COVID hit, and then the Speaker of Parliament had COVID. And they had to say he's moved to Nairobi. I think that is some of the news that was reported. And then at some point they said he was airlifted to the UK. So if this is the approach and that people in leadership are having to healthcare, then I think we're doomed. You wouldn't have to airlift the president of the States to move them to any country, even if they have a care system. Like I've just told you, Denmark, Norway, Switzerland, and all those countries in Europe, they have a better healthcare system, or the best healthcare system in the world. It still doesn't happen like that. We work with what we have. So even in Uganda, we just need to work with what we have. How are we going to expand such that we, close those gaps? How are we going to, motivate more healthcare workers to get into that space? how can we come up with accessibility options if people are not able to access it through government, like the MPs and all these other people who work for government, or people who are formally employed? Because I think those who are formally employed are able to access healthcare through, insurance schemes that companies are running out there. Now, what of the people who are in the informal sector? And we all agree that the informal sector is one of the biggest part of the population within the country. That's a very big sector or section of the Ugandan population to ignore. How can we have a reenactment of maybe the Affordable Act like the way they had it here, the Obamacare? It also came in later. Let no one deceive you that this is how it has always been here. Like I've explained, it has been gradual. Different presidents, different senates have argued for healthcare reforms until the US has what it has. And I'm sure it is no different from the countries that are doing well in Europe. So just toughening it out and being very practical on how we approach our problems as a nation. So the state or whoever is in power is free now to pick a leaf, and they do have conferences and all these other trainings that they come and take in places like here. I don't know why sometimes it is harder to to roll them out on a local in our local setup. It looks like when the South African leaders treat the hotels, picture moments, that's to the solutions they've gathered or learned in such places. It's another. Like my brother Barnabas has able to explain, we were supposed to commit to spending a lot more on healthcare, which we are not doing. Yes, I think we all know that we're spending more on guns and all these other things that are supposed to, at least they give the illusion of security and stability. But I think healthcare is probably as important, if not more important, because who are you going to protect at the end of the day? Who's going to work and pay the taxes that you need so dearly such that you can improve infrastructure and the rest? And of course, we can't neglect education, because education is so much dependent on the healthcare. It's the reason Uganda has not been able to open up its schools. It's because of healthcare. We don't have the facilities to handle a pandemic like COVID. So we decided to close down the schools, and we all know the trade-offs that we are making there, how big of a loss we are causing, not just to us, but even the future generation, because children have been at home for over 2 years. It's healthcare. It's healthcare that is in the way, which is sick, to say the least. So I think COVID would have been, this pandemic was supposed to give us a very good study case or so, or opportunity to actually roll out a few reforms. I understand they tried to use Namboli as, fields like Namboli and the rest to for the missing beds that we don't have, in even the missing hospitals that we don't have, such that they can cover that gap. It's just a little fortunate that the pandemic didn't hit us as hard as it was anticipated, and thank God for that. And of course, it's back to the people, the personal responsibility they took, and the measures they exercised from all the directives of the WHO and maybe the Ministry of Health. We can also attribute some of that maybe to the to the president's speeches that he used to make every now and then. But I'm sure it is the Ugandans themselves who actually did the most part to make sure that the pandemic doesn't wipe them out. So we are just looking at prevention at the moment, more than treatment or cure of most of the ailments that we have in healthcare, because we can't handle the others. So in Uganda, or in the local setup for most African countries, it is just better to prevent an illness than trying to handle it, because there's no structure, there's no hospitals to handle that, there are no beds, the pharmacies are all importing medicines, and God knows whether these are good for us. And of course, we're trying to build up some pharmacies, or other pharmaceutical companies down there, hardly. But again, at least that gives some hope that there's something being done, or there are people out there who are doing something to change the status quo. So, Doctor, I would just need to, I think, submit at that point. But I think all hope is not lost. We can definitely do better in Uganda. Thank you.
Thank you very much, Lawrence. I think it has been a good day as we try to discuss all these issues. And we try to wrap up, I think you all have tried to give a very good expression of how they feel and how our people look like in Ugandan structure. And as we try to, wrap up, I want everybody of you to have 2 minutes, and after which we shall be able to, go end up wrap up, and then we get out of here. Let's start with Barnabas. Barnabas, would you wrap up? What should we do?
All right, thank you very much. Like I said in the beginning, improving the healthcare system of our country, Uganda, is a collective effort for everyone, including the citizens themselves, and then the healthcare workers who are doing the practice in Uganda. Um, Something I want to bring out to the viewers. Sometimes it's people don't take healthcare system so serious that they only leave it to the healthcare practitioners. But I want to let you know that one of the ways of empowering our healthcare system is to empower the citizens of the country, to educate, go out and educate the public to make sure that they know their rights. They should know what they deserve to get. They should know what they should do in order to participate in contributing to a sound healthcare system. And when we empower the public, then we are building a very strong foundation that will make our healthcare system the best. Then the other thing is really to redefine the relationship between clients or patients and the medical or medical practitioners, the doctors and nurses. Um, there is a big gap between healthcare providers and the public. Like I said, when people come to seek for medical services and we don't do our best, we don't give them what they deserve, they end up fearing coming to the hospitals, and then eventually they don't obtain the services. So one of the ways we could help in ensuring that the healthcare uh, the healthcare that is obtained from health facilities by patients improve is to redefine the relationship between patients and doctors. Then we also really have to ensure that uh, our hospitals are equipped very well. When um, there is no when there are no medications, when there are no gloves, all the logistics to use, like I said, it makes life for health workers very, very difficult. The working environment becomes very hard, and then the clients or patients end up choosing the health workers of not doing their best, and yet the environment in which they are working is really not supportive. It wouldn't be supporting them. So we really need to work hand in hand to make sure that we bring all these aspects together to make sure that we make a strong foundation for a better healthcare system for our country.
Thank you very much, Barnabas. Thank you very much for the effort and the time you've given us, and we hope to have you more next time as we try to dig deep into some other issues that we really need to be effective in Uganda. Thank you very much. Let me go to Mr. Kisitu. Mr. Kisitu, would you please wrap up?
Thank you so much, Dr. Juko. Thank you so much, Dr. Juko. I understand that everyone needs a second chance. And what I can tell to the government of the Republic of Uganda, the health care that it provides to the army should be the same to the civilians. And it is beyond reasonable doubt that the army in Uganda has the best health facilities. And that is what we also need in our country, Uganda. Still, to all of us, the civilians, let's try as much as we can to always be very much vigilant about our health. And in case of any health complications, let us always report to the medical officers. Still, and as far as the recruitment is concerned, the government should try as much as it can to recruit doctors according to where they grew up from. It is already so bad to take a person to Karamoja, yet this person has already spent his life or her life in Luweero. The two regions do not correlate at all. They are very much different. So health is a very pertinent issue. I thank you so much, Doctor. I thank the management of UNN for always giving us this chance to discuss about the issues that are so much pointing so much to the civilian, the wananchi, wananchi, that's how the president calls it. I think the first beginning person. I pledge to be around again and next time when the opportunity is provided. I thank you so much. I beg to submit.
Thank you very much, Professor Kisitu. Thank you very much for the effort you usually put in as we try. We have not been able to finish up with Dr. Joel as he had some technical problem, but let me have Lawrence last, and then we wrap up. Lawrence, can you come and wrap up?
Yes, please, Nadine. Thank you so much for again another wonderful opportunity to be part of the Truth Command Center discussion at the Tower on the UNN. Well, I think I'll just end by probably just a little observation on what I've seen in the National Development Program that we have for 2020-2025. I think its main aim has been towards lifting most of the the Ugandan population out of poverty into prosperity. I don't know how that will be achieved, but there are some good points there on how to do that. Well, I might say that yes, today we're discussing healthcare, but to my surprise, not so much to do in terms of healthcare development when I look into the plan. And I think they focused on other areas. It's almost the same thing like when we were discussing education last time. It was so much hinged on how healthcare will perform. So how healthy people are will determine which sectors or education they would have and all that. And in this case, I just looked into the plan and I couldn't see so much of I didn't see the section for healthcare, but there's something about everything: tourism, minerals, private sector, digital, so many good things in the plan. But healthcare didn't seem to be something that they paid attention to. So maybe, I mean, right now we're in 2021. The plan is going to expire in probably 4 years. It's not so bad to start planning for the other 5 years if we missed it in this one. So till 2025, much might not change. Though I think there could be some sections that are talking about which infrastructure they might pay attention to in terms of the healthcare, maybe setting up a few hospitals. And of course, right now with the plans to have more people trained in sciences and all that. But that said, I hope whoever has access to some of these programs and more information they could pick at it from places that have done it better, and then we do it as good, even better, because that is what most of the they always learn from each other and then leverage on each other, use each other's synergies in order to get the best out of each and every one. So in terms of healthcare, it's not a lost battle. I think for the most part, Ugandans are doing a good job all by themselves. Now it's just part, it's now back to the, those in power to also do their part to see that they include those who do not have access to healthcare, such that they might be able to access it in some program in a way, whether insurance, state insurance, or private, whichever way, such that it is affordable. Just looking at just getting money, like they say, just to lift people out of poverty is just not enough, because how other people, be for us. I think they need to be healthy as well. And of course, we need to watch the population clock. It's climbing too high. Like I've told you, the most healthy, the best healthcare systems are actually in countries that have the least population. So we need to watch that as well. That doesn't mean that we should not have kids at all. I think we should, just not probably at the rate at which we are having them. Having some of these issues that have come out in the pandemic, children who are supposed to be in school are having right now. That is also very worrying on how the realization of certain goals is going to be more so in healthcare and other cases. And on that note, I beg to meet. I thank our viewers for tuning in, and all fellow panelists, Barnabas, Joe, Chisitu, and of course, Dean, our host. Thank you so much.
Thank you very much, viewers. Thank you very much, our discussants. We cannot go beyond this time, as time is money. So the most very important thing is that we always come here with topics. Our viewers and Uganda at large benefits from all these discussions. We pray that the viewers keep the discussion on in all our platforms, so that we can be able to extend this very important information to all our people. Uganda needs our services, our expertise. We need to come out all out as people of Uganda to make sure that we obtain the best. Uganda needs a federal system of governance, which system of governance would help for people to have developing their own places of work, places of origin. When we have people working with their own people, they tend to have a lot of empathy, whether it's the police or the army or health workers and everybody. They tend to have that empathy. So the best way to do that is having a good governance with division and federation of those states where we come from. Thank you very much, viewers. Thank you, Dr. Samson, our producer. Thank you, the back end of our UNN, the tower, and everybody that has done much to make sure that we do this program in the best way. We thank also the viewers for the time and money that they put in to watch our shows. Keep doing that. Also support us in all way by clicking on our links, and then be able to donate anything that you can do. Go to our websites. We also inform you that UFCC is about to start. So please keep in touch. Thank you very much. Have a blessed day. Have a good week, and we see you once again on Sunday, the same time. Bye-bye. What happened? The day